Myofascial release and trigger points. There are different names for these techniques, including myofascial release, myofascial stretching, strain counterstrain, rolfing, and soft tissue mobilization. Myofascial release is a close relative to massage. Myofascial release involves the manual contact with a patient to evaluate a problem and perform an effective treatment. There are many variations of myofascial release, but they all use the same principle: the use of manual contact for the evaluation and treatment of soft tissue restrictions and pain, with the eventual goal of the relief of those symptoms to improve motion and function. There are many different variations, forces, applications, and techniques, and therefore research on the effectiveness of these treatments remains elusive. To understand myofascial release, we need to know what fascia is and how it functions. Fascia is a continuous connective tissue structure that surrounds and integrates tissues and structures throughout the body. Fascia establishes an interconnectedness of the body. Fascia varies in density and thickness with the structures it surrounds. Fascia is vital for tissue form, lubrication, nutrition, stability, integrity, function, and even support. There are 3 layers of fascia. The superficial layer is attached to the undersurface of the skin and includes the capillaries, lymph vessels, nerves, and fat. It permits the skin to move in many directions. This is also the area where edema accumulates following injury. The deep fascia is dense connective tissue that surrounds and separates deeper structures such as muscles, tendons, joints, ligaments, and bone. Deep fascia are stiffer, therefore it is less able to accommodate edema, which can result in some different types of injuries such as compartment syndrome in the lower extremity. The final layer is seborrheic fascia, which surrounds internal organs. Its loose areolar connective tissue contains channels where fluid assists in providing the organs with lubrication. Myofascial release techniques do not treat fascia surrounding the visceral organs. The fascia contains collagen, elastin, cellular components, and ground substances. The elastin within the fascia allows the structure to return to its original shape when applied stresses are released. Fascia also responds with plastic deformation when prolonged forces are applied. Creep and hysteresis are properties of fascia and are impacted with myofascial release techniques. The properties of myofascia: it has tensile strength. Collagen fibers can support 10,000 times their own weight. Elasticity: elastic fibers can stretch 150% and can return without damage. Compressive strength: bonded water molecules resist compression. Viscoelasticity and plasticity: these are time-dependent deformations that are resistant to shear and strain forces. Thixotropic: this means that the tissues are decreasing in their viscosity when subjected to force over time. Mechanotransduction: this is the intracellular or cytoskeleton and intracellular, also known as the extracellular matrix, transmission of kinetic energy and physical strain to absorb, dissipate, and adapt and/or repair a structure. Excitability and contractibility: the tissue responds to mechanical strain and cytokines by transforming fibroblasts into myofibroblasts. These are used to counteract chronic tension or close off wounds. Myofibroblasts normally degrade when wound healing or enough collagen has been laid down to counteract the strain. Structural biotensigridity: this is the biomechanical concept of how fascia contributes to structures of the human body. All bones of the skeleton are suspended within fascial layers, not the other way around as are traditionally thought. Stress and strain absorbed in one place is readily distributed through the entire structure. We have invented other material that is stronger or more elastic or more resistant to damage, but there is nothing as versatile as healthy living fascia. Fascia cannot respond immediately to the electrical chemical signals of the efferent nervous system like muscle fibers, which is maybe why it's often ignored by some clinicians. But it is extremely responsive to kinetic energy, such as pressure, tension, and shear forces, and we try to use these responses in myofascial release therapy. For better or worse, myofascia is continually tensed by intrinsic tension and active contractions. Misuse, disuse, or overuse injuries that can cause pain and or imbalances can be tuned to find better balance within the myofascial release and function training. More specifically, we're interested in muscle fascia or myofascia, which is in turn a type of deep fascia. When you sprint, it is not just your muscles and your tendons that provide the energy to rebound, but also the fascia, particularly those fascia tissues with tendinous or aponeurotic properties. When you stretch, your fascia needs to be stretched too. Fascia can withstand high tensile strength and tolerates multidirectional compression, stretch, and shear force as well. Injury can affect fascia as well as other tissues. Fascia is far more than just a supportive, springy wrap, though. It contains blood vessels and sensory receptors. Fascia has between 6 and 10 times more nerve endings than the muscle. Fascia also contains its own smooth muscle cells, which are thought to contribute to fascial contractility. Fascia is a band or sheet of connective tissue, primarily collagen, beneath the skin that attaches, stabilizes, encloses, and separates muscles and other internal organs. When healthy, 2/3 of fascia consists of water, allowing muscles to glide and contract, producing force, or extend, which is stretching. When we are young, fascia have a lattice-like wavy, crimp pattern that resembles an elastic coil. This coil stores up kinetic energy, allowing our muscle fibers to glide smoothly. As we age, however, the pattern becomes irregular, and motions become jerky unless we move the whole body every day. Regular movement of each muscle keeps the crimp, as well as keeping your fascia flexible and fluid. But if you are always moving quickly, you miss the fascia. In order to move fascia to keep it healthy and flexible, you must move slowly. Myofascia maintains an intimate relationship with the muscle it covers and surrounds. The muscle and the fascia provide the combined contractile and non-contractile properties of muscle. Myofascia increases muscle strength during eccentric contractions, and the myofascia provide vital support to permit normal muscle function. When injury or unbalanced biomechanical forces are applied to myofascia, muscle function is impaired. This impairment leads to pain, loss of motion, and reduced functional performance. Muscle dysfunction causes additional changes in the myofascia. In chronic pathologies or pathologies that occur over time, muscle imbalances are likely to occur. For example, a soccer athlete who has poor posture and develops a muscle imbalance. This process may have begun with a minor trauma or injury, which then resulted in a change in the muscle, perhaps as part of the muscle's withdrawal reflex to the injury. The muscle change causes the imbalance of the muscle strength between the agonist group and the antagonist group. Imbalances in muscles can lead to changes in neuromuscular responses and coordination, which could lead to further imbalances until the structure reaches a point where the imbalance and the increased tissue stress causes symptoms that result in impairments in performance and require treatment. Myofascial restrictions can occur within a short time from acute injury and scar tissue formation, or gradually from minor but progressive alterations from repeated low-level trauma. There are a number of other factors that result in fascial changes and affect performance or produce pain. Some of these examples may include leg length differences, inadequate rehabilitation from previous injuries, worn, poorly constructed, or ill-fitting shoes and protective equipment, prolonged activities that overstress supportive structures, and even poor ergonomics. If any of these factors are present but not actively addressed, these factors will produce an imbalance of strength, flexibility, and fascial mobility, so the body or the segment is abnormally stressed and creates an environment that makes the individual susceptible to injury. Exercise is a vital collaborative adjunct of myofascial release treatments in a successful rehabilitation program. Myofascial techniques release the restricted areas, but exercises for flexibility and strength reset the neurological programming. Together, they cause a permanent positive change in the affected tissue. Scar tissue is less extensible and creates a localized connective tissue meshwork of tentacles outward. This can sometimes look like a shattered plate glass window to adjacent locations and can limit the normal tissue mobility. From our discussion on immobilization, the scar tissue matrix can restrict neuromuscular and lymph vessels and reduce the local metabolism. With reduced metabolism, a fluid imbalance further adds to the area's reduced mobility and continued inflammation. Less motion causes a loss of hyaluronic acid, also known glycosaminoglycan, or GAGs, and promotes increased cross-link formations, and mobility becomes restricted. Spasms can also influence the fascial system by producing prolonged tightness in one area that causes another area to compensate with prolonged looseness, initiating a cycle of imbalance and fascial pathology. The term myofascial release has been referred to as soft tissue mobilization. This term is actually quite common, but it's actually a misnomer. Myofascial release implies the treatment to myofascial tissue. Although we can target the myofascia during the treatment, it is not always the targeted tissue nor the only tissue treated. Palpation is fundamental in myofascial release. Palpation is not only required for the examination of the area to identify the tissues affected, but also during the treatment to assess the effects of the treatment. Soft tissue extensibility, movement, infeels, and responses to treatment should be palpated before, during, and after treatment. Normal tissue has no tenderness when it is palpated. Normal tissue should have a springy infeel that can be palpated when pressure to tissues is released. The release is the treatment goal and is necessary for restoring tissue mobility and balance. The release that is palpated has been described as the tissue giving way, letting go, relaxing, or melting as ice with a hot knife going through it. When using the myofascial release techniques, you should move from superficial structures to deeper structures to avoid a mistake in identifying the structure or the tissues that are actually restricted. We need to be careful of the amount of force we are applying to the structure. More force may be indicated when scar tissue adhesions and reduced mobility are present, but this should only be employed after examining and assessing the area and determining the patient's level of tolerance to the treatment. Autonomic changes can occur when the restriction is released for the individual. If pain and fascial restriction causes change in the skin color, moisture, temperature, and sensation, then their release will also cause changes in those signs and symptoms. Afferent sensations are transmitted to the dorsal horn of the spinal cord. The dorsal horn is a processing center that receives and redirects information. It can send an impulse directly out of the spinal cord as a reflex efferent response, or it can send information to the subcortical or cortical level of the brain, where it is interpreted and a response is formulated and returned down to the spinal cord to the appropriate location. The patient may experience an autonomic response when treatments are particularly effective. When the sympathetic system is stimulated, the patient may have symptoms such as increased pulse rate, sweating, and blood pressure changes. Less intense responses include the sensations of burning, tingling, stinging, or heat in the area being treated. Although these responses are unusual, you should be aware that they can occur and be prepared to respond appropriately. The general guidelines for treatment techniques. We need to restrict treatment time to 3 to 5 minutes to start. If bruising occurs, the technique is too aggressive. Bruising can cause additional scarring and adhesions, so it should be avoided. Temporary redness is okay and should be expected. There are many ways to perform myofascial techniques. One of the most frequently used techniques is the longitudinal myofascial release. Both hands move longitudinally in opposite directions while stretching the tissues. In other variations, only one hand applies the treatment while the other hand stabilizes or supports the tissue. The treatment hand applies pressure through the finger pads, thumb, knuckles, or even the heel of the hand. The pressure can also be applied through the forearm or the elbow, depending upon the size and the location of the area being treated. The tissue slack is taken up and a steady pressure into the restriction is continued until the area releases, or for about 90 seconds. The amount of pressure applied is determined by the tissue involved and the sensitivity of the area, but is generally a low-load, sustained pressure. The J stroke is a common direct technique used on limited areas of tightness on longitudinal scars. The treatment hand draws short J's across the restricted area. Oscillation. When the muscle spasm is present, a direct technique such as an oscillating pressure technique can be used. This technique involves a rhythmic back and forth application of a low load pressure while maintaining constant contact. This is designed to relax the muscle by reducing the spasm and relieving the patient's guarding of the area. Ringing. In other areas of generalized or multidirectional restriction, a direct technique referred to as ringing can be effective. Both hands are used for this treatment. The hands are placed on the area and they rotate on the extremity in the opposite direction to twist or ring the tissue. This can be used on smaller areas using 2 thumbs in the same manner. Stripping. The stripping technique is used as a deep tissue release. This is applied directly to the restricted deeper tissues. Knuckles and the elbow are frequently used in this technique, but the finger pads can also be effective in smaller areas. The pressure is slow, constant, and deep. This treatment is not as comfortable for the patient, but if it can be tolerated, it is effective in breaking up deep adhesions. An arm pull or a leg pull are gross techniques applied for generalized tightness in the upper and lower extremities. The clinician applies a longitudinal traction to the arm or the leg from the hand or the foot where the patient is lying supine. As the traction is applied, the extremity is slowly moved into abduction and external rotation. When tissue resistance is felt, the motion is stopped and the position is maintained until you feel the extremity release. Once the area releases, the extremity is passively moved throughout its arc of motion into the new area of restriction, and this sequence is repeated until an in position is reached. The precautions and contraindications. Precautions. Be careful with new scars. They have reduced tensile strength, increased sensitivity, and they may have a limited tolerance to pressure. We need to be aware and careful of complex regional pain syndrome and reflex sympathetic dystrophy. Patients should be warned that sensations of pain, tingling, burning, and warmth may occur and are considered normal sensations. Our patients should let us know if they're feeling other sensations, though. Contraindications: malignancy, hypermobile joints, recent fracture, hemorrhages, sutures, osteoporosis, local infections, and acute inflammation. Myofascial trigger points. A trigger point is a focus of hyperirritability in a tissue when compressed, is locally tender, and if sufficiently hypersensitive, gives rise to referred pain and tenderness, and sometimes to referred autonomic phenomena and distortion of proprioception. There are many terms that are used interchangeably with myofascial trigger points, including myalgia, fibrocystitis, muscular rheumatism, fibroblastic syndrome, myositis, and myofasciitis. Trigger points can be located in cutaneous, fascial, myofascial, ligamentous, and periosteal tissue. Myofascial trigger points are a taut band of muscle and tissue in the surrounding fascia. They're palpated as a nodule within this tissue. Compression of this point often refers pain to other areas or causes that autonomic response. There are different types of trigger points. Active trigger point is one that is always tender and can produce referred pain, whether the muscle is active or inactive. The muscle can display weakness or reduced motion. There is a twitch response with rolling pressure, also known as a snapping palpation. This snapping palpation is performed using firm, constant pressure, moving the fingertips across the muscle fibers as if plucking a guitar string. The local twitch response is an involuntary contraction of the muscle fibers in response to the snapping palpation. This response is sometimes called a jump sign, but that is incorrect. A jump sign is a reflex response, but it is a reaction to wincing or withdrawal by the patient. A latent trigger point is painful only when it's palpated. Normal muscles do not have areas of tenderness, sites that elicit local twitch response, or palpably taut bands. Some common trigger point characteristics. They may be a dull ache, even moving into intense pain. There is commonly referred pain patterns that are unique to each muscle. The referral patterns do not follow neurological patterns, and the sensation of the referred pain is different than neurologically referred pain. Some descriptions that people have used is sharp stabbing pain, and it's rarely described as burning pain. Some different causes of trigger points. These could be from injury, overload, fatigue, or even from cold. This can also be from acute conditions such as fractures, sprains, dislocations, muscle impact injuries, and the stress of excessive exercise. Some different trigger point treatments. A vapocoolant spray is used on the tissue, or ice can also be used while a stretch is applied. This may be the most effective treatment for trigger point pain. The rate at which the ice or the vapocoolant is moved over the skin is approximately 4 inches per second. Ischemic compression. Pressure is applied slowly and progressively over the trigger point as the tension in the trigger point and its taut band subsides. Pressure is maintained until the tenderness is gone or until the tension is released. We then stretch the muscle. This may be the best and most effective decrease in trigger point pain levels. Stripping is a deep stroking massage that is applied with minimal lubrication on the fingertips. A firm pressure is used along the length of the taut band. Pressure increases progressively with each successive pass along the muscle. The taunt band relaxes and the trigger point nodule softens, and the area stops being so tender and no longer refers pain. The ischemia produced by the pressure of the compression or stripping massage is believed to cause a reflex hyperemia, returning the site to a normal condition. PNF techniques of the contract-relax or reciprocal inhibition can be used in combination with soft tissue mobilization to relax trigger points as well. Some precautions for trigger point treatment. Take a good history to determine the tissue that is affected. The patient needs to relax during treatment. Although some of these treatments can be painful, relaxation is key. Prolonged pressure over nerves and blood vessels should be avoided, so you need to know your anatomy. Ischemic compression should be discontinued if the patient complains of numbness or tingling.